Now we should shift over to congestive heart failure. The most important lab here is BNP or natriuretic peptides. BNP is incredibly valuable when evaluating dyspnea and helping us determine is this cardiac or is this pulmonary. It also helps to stratify congestive heart failure severity, management, and monitor treatment response. So, understanding this BNP physiology will strengthen your ability to interpret borderline or conflicting results and further support diagnostic reasoning. BNP is released from the ventricular myocardium in response to an increase in wall stretch and volume overload. It plays a key role in regulating blood pressure and volume by promoting natriuresis and preventing excessive salt and water retention. Clinically, BNP helps differentiate CHF from COPD or pneumonia and is especially helpful when the physical exam or chest x-ray is unclear because it reflects ventricular strain. BNP can become an important biomarker for both diagnosis and prognosis. BNP acts as your body's natural counter-regulatory mechanism to heart failure. When the ventricles stretch, BNP is released and works to reduce volume and pressure. It suppresses the sympathetic nervous system and the ROS system, which are usually overactivated in CHF. And BNP promotes natriuresis and diuresis. It decreases peripheral vascular resistance and induces smooth muscle relaxation. So when BNP rises, it's essentially the heart calling for help, trying to offload volume and decrease afterload. This is why BNP levels correlate with the severity of heart failure. BNP production, we can see kind of this through this slide. When we have increased end diastolic pressure, that leads to increased stretch on the left ventricle, which triggers the release of a BNP precursor, pro-BNP, that then gets converted into or I guess it's pre-pro BNP, which then gets converted into pro-BNP. And then that gets cleaved into two parts, active BNP and inactive NT pro BNP fragment. Both are measured clinically, um, but BNP acts directly on target tissues through cyclic GMP signaling, promoting active things in the body like vasodilation and diuresis. And so the physiology here helps to explain why BNP levels elevate early during volume overload and why NT-pro BNP is sometimes actually preferred because it has a longer half-life and actually is more stable. When would we order this, though? BNP is useful in distinguishing a CHF exacerbation from other causes of acute dyspnea, such as COPD, pneumonia, or pulmonary embolism. When a dyspneic patient presents and the exam is unclear, BNP can dramatically narrow your differential. It's also used to risk stratify severity and predict prognosis during acute exacerbation. A key clinical pearl is patients whose BNP decreases by more than 50% during hospitalization have significantly lower rates of readmission and mortality. So BNP is not only diagnostic, it's prognostic and even therapeutic. A normal BNP is typically less than 50 to 100. NT-BNP has a different range. It has age-based thresholds because it raises naturally over the time with age. So a BNP of less than 300 is typically considered normal. A BNP of greater than 400 strongly suggests CHF as the cause of dyspnea, with fairly good sensitivity and specificity. If you're using NT-proBNP, the cutoffs are higher in older adults. It's greater than 450 if yet less than 50 years old, greater than 900 if 50 to 75, and greater than 1800 if 75 plus. Recognizing these cutoffs will be essential for your clinical interpretation, especially in a mixed pulmonary cardiac presentation. BNP also correlates nicely with our NYHA classification of heart failure, New York Heart Association. Patients with class 1 disease have a median BNP around 80, whereas class 4 patients have BNPs that are very high, over 1100. These numbers can help you gauge the disease severity and can strengthen your diagnosis when the picture is uncertain. Remember that obesity can artificially lower BNP levels. sometimes substantially. So a low BNP in an obese patient does not rule out CHF. You always must interpret through the lens of body habitus in this case. BNP can also be a powerful predictor of mortality and cardiovascular events, as levels above 200 are concerning and outpatient goals are typically less than 100 for BNP and less than 1700 for NT-pro BNP. Persistently high BNP levels correlate with higher hospitalization rates and mortality, so trending BNP over time is clinically meaningful. This is one of the few biomarkers in cardiology that functions as a true quote unquote vital sign, reflecting both hemodynamic strain and long-term outcomes. There are other conditions that increase BNP. It's not exclusive to heart failure. Left ventricular hypertrophy or myocarditis, pulmonary hypertension, renal failure, cirrhosis, and even endocrine disorders, such as primary hyperaldosteronism, can all elevate BNP. Certain medications, such as digoxin and beta blockers, can also increase BNP levels, and these are both used in CHF management. We'll also see BNP naturally be higher in older individuals and women or AFAB persons. So the message is a moderate increase in BNP must be interpreted alongside the full clinical picture. Now, just as factors can increase BNP, there are things that can lower it, such as medications like diuretics, ACE inhibitors, and angiotensin receptor blockers, or ARBs. All of these reduce BNP because they reduce preload and afterload to the heart. Patients with diastolic dysfunction or heart failure with preserved ejection fraction can have normal or only mildly elevated BNP despite significant symptoms. This is a really big diagnostic challenge then for doctors. Also, patients that have early pulmonary edema within the first hour may not have an elevated BNP yet. So, normal BNP does not entirely exclude heart failure. Let's look at a case. A 58-year-old female with a past medical history of type 2 diabetes and chronic kidney disease presents to the clinic with complaints of progressive shortness of breath and bilateral ankle swelling. Her medications include metformin, lisinopril, and a thiazide diuretic. Metformin is used for diabetes. Lisinopril is an ACE inhibitor for hypertension, and a thiazide diuretic is also often prescribed for hypertension and fluid overload. On exam, you note elevated jugular venous pressure, bibasilar crackles on lungs, and 2 plus pitting edema in both ankles. All of these are classic signs of volume overload and heart failure. Her blood pressure is 160 over 90, which is hypertensive, and her heart rate is normal at 86 beats per minute. You suspect heart failure and decide to order a B-type natriuretic peptide, BNP, level along with other investigations. Because this patient has chronic kidney disease, this will complicate interpretation because renal impairment can increase BNP levels. So cases like this are common and highlight the importance of integrated BNP physiology with comorbidities when making a diagnosis. So given the actions of BNP in the body, which of the following effects are directly attributable to BNP in the context of heart failure? We have stimulation of the renin-angiotensin-aldosterone system, leading to increased blood volume and increased sympathetic nervous system activity, resulting in increased heart rate and blood pressure. Both of these are actually the opposite of BNP's effect. Induction of natriuresis and diuresis, leading to decreased blood volume and blood pressure, is the actual definition of what BNP does. And then D, increased peripheral vascular resistance due to smooth muscle contraction contraindicates or contradicts the vasodilatory smooth muscle relaxing action of natriuretic peptides. So this, if you really know what BNP does in the body, you can answer this question correctly, which the correct answer is